Hello, everyone. Today I bring you another exciting lecture in pharmacology. Take a seat and let's enjoy. So as usual, this is Professor Kennedy Edem Kukuya, and today we explore calcineurin inhibitors. Calcineurin inhibitors. So what are calcineurin inhibitors? These drugs are a group of immunosuppressive agents that, as the name suggests, work by inhibiting calcineurin. Now, when we say that they are immunosuppressive agents, we basically mean that these are drugs that may depress your immune system activity. And there are many conditions that we may use them for, or there are many situations where we would need to use an immunosuppressive agent, and we'll explore that later. We have examples such as cyclosporin, tacrolimus, pimecrolimus, and then voclosporin. Now, the last two are newer agents compared to the first two. So how exactly do these drugs work? How do they work? In exploring how they work, first, I would want us to look at how immune response could occur, and using that, we'll then bring in how these drugs could suppress that immune response. So to begin, let's say this diagram is our T cell with a T cell receptor here, our calmodulin in the cytoplasm, calcineurin also in the cytoplasm, our nucleus with its nuclear material. And let's assume that we bring in an antigen-presenting cell. It could be a macrophage, which is presenting an antigen on its major histocompatibility complex to the T cell receptor. Now, this interaction would cause the release of calcium or calcium influx. The calcium that has been released would then bind to calmodulin to form a complex, and then that calcium calmodulin complex would then bind to calcineurin. The complex from the calcineurin calcium calmodulin complex would then activate nuclear factor of activating T cell, which is a transcription factor. That activation will cause the hydrolysis of the phosphate group, which then allow the transcription factor to enter the nucleus. On entering the nucleus, the transcription factor then causes gene transcription, which then leads to the synthesis of various pro-inflammatory cytokines like interleukins and TNF-alpha. These then move out of the nucleus and the cell to activate or to promote immune response. And so now that we understand how they promote immune response, let's look at how these drugs that we talked about would inhibit that immune response. So we pick tacrolimus and then we pick cyclosporin. Now we bring back our diagram. If I should give cyclosporin, it binds to an immunophilin we call cyclophilin. Then if I should give tacrolimus, that binds to another immunophilin we call FKBP12. Now, for tacrolimus, apart from binding to this FKBP12, it also binds to calcium calmodulin complex. So those four entities then form a complex, and they then inhibit the interaction of calcineurin calmodulin complex with the transcription factor. So without this interaction occurring, we will not activate the transcription factor, and so the transcription factor would not move into the nucleus to induce transcription. And without the transcription, it means that the synthesis of these pro-inflammatory cytokines will reduce, and then the immune response would be suppressed. So I hope this is simple enough for all of us. Now let's look at the pharmacokinetics of these drugs. Usually, anytime we talk about the pharmacology of any drug, it is important to look at the pharmacokinetics. And today we will look at that. So aside pimecrolimus, which is usually a topical preparation, the rest can be given orally, okay? And their oral absorption varies from patient to patient and on the basis of whether there is food in the GIT or not. And so we could have the absorption being between 20 to 50%, depending on these factors. And this may influence the onset of action, the duration of action, and the intensity of action of the drug. Now, for cyclosporin, we also have the intravenous formulation, and we have the ocular preparation. Voclosporin is basically an oral medication, all right? Now we look at the metabolism. When these drugs are administered, mostly they are metabolized in the liver using cytochrome P453A family. We have the 3A4 and then the 3A5. Now, anytime you think of this 3A family, you always think of the possibility of drug-drug interaction. And that is so with these drugs. You give them, there is a high tendency for drug-drug interactions. Now, for cyclosporin, it is also metabolized partially in the kidney and in the gastrointestinal tract. Usually, there are interpatient variability when it comes to how these drugs are metabolized. So for some patients, the drug may be metabolized quickly. For others, it may be metabolized slowly. And because of that, it means that we would have to individualize the dose when administering these drugs. Then how are they eliminated? For majority of these drugs, except for the one that is administered topically, that is pimecrolimus, these drugs are eliminated through the biliary route. So as they are metabolized in the liver, they then pass through the bile duct and eliminated through that route, but they end up in the fecal matter. Now, since they don't depend on the renal system for their elimination, usually patients undergoing dialysis or patients with renal failure do not need any dose adjustment when administering these calcineurin inhibitors. Now, what about their clinical indications? What do we use them for? One, we could use them to suppress immune response that may try to cause a rejection of an organ that has been transplanted to a recipient. So let's say someone who needs a solid organ transplantation, a kidney transplant, a liver transplant, and this person has received or is supposed to receive the organ, but we don't want the organ to be rejected by the recipient. So we would give this immunosuppressive agent to suppress how the immune system will try to attack the organ that has been received. We could also use it in what we call graft versus host disease after we have done a hematopoietic stem cell transplantation. Then in various autoimmune diseases, it could be rheumatoid arthritis, it could be psoriasis, it could be systemic lupus erythematosus. Then we could also use this in dry eye, severe dry eye syndrome. Now let's take a look at various adverse effects associated with this drug. One of the primary adverse effects is nephrotoxicity. In fact, in situations where we've done kidney transplant, the challenge with the nephrotoxicity would be to differentiate between whether it is the drug causing the nephrotoxicity or the nephrotoxic effects we are seeing is because the kidney is being rejected. The patient could also have hypertension. I think about 50% of patients that receive these calcineurin inhibitors are likely to develop hypertension. It may be necessary to monitor the blood pressure of these patients. Then there could be neurotoxicity. It may manifest as headache. It may manifest as seizures. Patients could have hepatotoxicity, where there could be elevations in liver enzymes. there could be some metabolic disorders like hyperglycemia. And in fact, with the hyperglycemia, this may actually lead to diabetes. So we say these drugs are diabetogenic. There could also be hyperuricemia leading to gout. There could be hyperkalemia, and then there could be hyperlipidemia. Now, there may be differences in how these drugs present with these side effects. For instance, cyclosporin is known to show more of hyperlipidemia as compared to tacrolimus, right? And when it comes to hyperglycemia, I think tacrolimus has a higher tendency of causing diabetes than cyclosporin, although they all produce that effect. Then again, patients may be at risk of lymphomas and other forms of malignancies or cancer. Lastly, we would like to look at drug interactions. You'd remember I mentioned that because the drugs are metabolized by cytochrome P453A family, there is a high tendency for drug-drug interaction. So there could be interactions between the calcineurin inhibitors with glucocorticoids. This may present with a higher tendency for diabetes, where the patient is taking drugs that are enzyme inhibitors or enzyme inducers. This could either cause these calcineurin inhibitors to stay in the system longer or to be cleared faster. And because they have narrow therapeutic index, it means that if they are cleared faster, there is a tendency for the drug not to work. If they are cleared slowly, there would be a tendency for severe adverse effect. So this may require that we monitor the drug when the drug concentration, when the patient is taking other drugs with it. It's also possible that by combining with NSAIDs such as aspirin, diclofenac, ibuprofen, or sirolimus, which is another class of drug, these drugs have been shown to increase the tendency for nephrotoxicity. We also know that there could be interaction involving the calcineurin inhibitors and methotrexate. Then, lastly, interaction between calcineurin inhibitors with grapefruit juice. Now, please remember that grapefruit is not the same as grapes. Grapefruit looks like orange. Now, the juice from this fruit, within the juice, we have certain molecules that have the tendency to inhibit various metabolizing enzymes. And so by inhibiting those metabolizing enzymes, the metabolism of cyclosporin and the other drugs would be impaired, meaning the drug would accumulate in the system, leading to toxicity. Normally, we advise that patients do not take the calcineurin inhibitors together with this grapefruit or grapefruit juice. Now, this all time would allow us. I'd want to thank you for making it a point to watch this video. As usual, we would advise that you subscribe to our channel, you like, comment, and share as freely as you can. We will meet you another time. This has been Prof. Kennedy Edem Kukia. Bye for now.